right, Catherine, whenever you're ready.
All right. Good evening, everyone. I am Catherine Lightfoot, the Director of Healthcare at EEPB, a large local CPA firm here in Houston, Texas. I am a CPA and a certified healthcare business consultant. I spend my day reviewing numbers because I believe better data is better decisions. I mean, at the end of the day, the numbers don't lie. You may not like the answer, but they don't lie. I would like to welcome everyone to the panel presentation and discussion on palliative care, a timely topic that has become even more important with the increased morbidity associated with the COVID pandemic. I want to remind you that you can submit your questions for the panel in the chat and also use that as a tool for directly messaging participants or to facilitate discussions for all present. I've been on some of these groups before, and sometimes your chat box goes like this. So it's a good group. Let's keep it lively. We would like to thank our chapter sponsors for their support for this program and our other educational events. Our charter member sponsors, Texas Children's Hospital, Houston Methodist, CHI St. Luke's Health, Memorial Hermann Health System, MD Anderson Cancer Center, and HCA Houston Healthcare. Our Diamond Plus sponsors, Metastar, and the Intercontinental Houston Medical Center. Our platinum partners, Perlmeyer, Page, J. Tire Health, Harris Health, University of Houston Clear Lake Center for Executive Education, Kindred Healthcare, Luminari, and EEPB, as well as our silver sponsors, Texas A&M University, Brazosport College, Candale Partners, and the UT School of Public Health. Please note that there are several upcoming events of interest, all of which you can register for at www.ache-setc.org. Next Wednesday on June 23rd, we're holding a virtual mini conference on diversity, equity, and inclusion. This will feature John Burroughs as the keynote in an opening session that grants virtual ACHE face-to-face credits. That Friday on June 25th, we have a virtual guided tequila tasting with Jason Ruth, featuring amazing tequilas that most would never get a chance to try. All proceeds go to the scholarship fund. On July 15th, we are holding a networking event, Coffee with the Chief, featuring Greg Harrelson of Memorial Hermann. On July 22nd, bring your family and friends and join the ice cream social. And on July 30th, there will be a panel session on administrative fellowships. There will also be a not to miss virtual humor happy hour with Andrew Tarvin on Thursday, August 26th. I listened to one of his TED Talks later this afternoon because I needed a little dash of humor today. So that's something to look forward to. There's going to be many other events that Mark is working on and the group is working on for August and later on in the calendar. So make sure you are signed up for the newsletter and also on the LinkedIn group to keep in touch with these other upcoming events that will be scheduled. Now, those are the announcements. I'd like to get us started and with Katrina Melton, who's going to start tonight's session. Katrina Melton serves as the Vice President of Post-Acute Services for Memorial Hermann Health System. Katrina is responsible for the strategies and operating models for all post-acute services within the system, as well as for the system's aligned networks, including Memorial Hermann's owned audit and pediatric hospice programs. Additionally, she collaborates at all levels of the organization, building out strategies and standardized programs for their chronically ill populations to result in improved outcomes, experience, and total cost of care. Katrina, I'm going to turn it over. It's all yours.
Thank you so much. I'm honored to be here this evening, and I am thrilled to moderate this panel. I have the opportunity and honor to be able to introduce our panelists this evening, or our other panelists this evening. So Dr. Patricia Bomba is a nationally and internationally recognized palliative care expert. She currently serves as the Senior Medical Director of Geriatrics and Palliative Care for Exelis Blue Cross and Blue Shield. Dr. Bomba is a founding member of National Post, a member of the Executive Committee for the National Plenary Assembly, and chairs the Federal Public Policy Committee. She is also a member of NCQA's Geriatric Measurement Advisory Panel, and she served on the Institute of Medicine's committee that produced Dying in America, Improving Quality of Care for People with Serious Illness. Early in her career, Dr. Bomba spent nearly 2 decades in private practice where she focused on the care of the frail elderly with multiple comorbidities. During that time, she served as the medical director of a 160-bed long-term care facility where she developed the first physician-nurse practitioner team model in 1983. Dr. Bomba is the author of several articles on issues related to advanced care planning, palliative care, elder abuse, and end-of-life concerns. She is board certified in internal medicine with added qualifications in geriatric medicine. In addition, Dr. Eduardo Brera obtained his medical degree from the University of Rosario in Argentina. He relocated to the University of Alberta in 1984, where he established the Edmonton Regional and Palliative Care Program. In 1999, he joined MD Anderson, where he currently holds the F.T. McGraw Chair in the Treatment of Cancer and is the chair of the Department of Palliative, Rehabilitation, and Integrative Medicine. Dr. Barrera's main clinical interest is in the care of the physical and psychosocial distress of patients with advanced cancer and the support of their families. Internationally, he has helped establish palliative care programs in Latin America, India, and Europe. He holds leadership roles with the World Health Organization, the Multinational Association of Supportive Care and Cancer, and the International Association of Hospice and Palliative Care. Dr. Barrera has more than 1,000 peer-reviewed publications and has edited 31 books. In addition, he has received several national and international awards, including the American Cancer Society's Lane Adams Quality of Life Award and the American Academy of Hospice and Palliative Medicine's Lifetime Achievement Award. Our fourth panelist, Mr. Schaefer, was the founding chairman and CEO of WellPoint, now Anthem, and was chairman and CEO of its predecessor, Blue Cross of California. In the federal government, he served as the administrator of healthcare financing and administration, now CMS, with responsibility for Medicare and Medicaid. Currently, he is senior advisor to Star Investment Holdings and director of SC Pharmaceuticals. He is also the Judge Robert McKay Windy Chair and Professor at the University of Southern California. He is a trustee of USC, the RAND Corporation, and the Brookings Institute, where he is vice chair of the Brookings Board. He is a member of the Board of Fellows of Harvard Medical School and chairman of the USC Health System Board. He established the Schaefer Center for Health Policy and Economics at USC and chairs its advisory board. The Schaefer Center includes aging and end-of-life issues in its policy research agenda. He also established the Schaefer Fellows in Government Service Program, which supports undergraduates in paid government internships. He is a member of the National Academy of Medicine. At the National Academy of Medicine, he was a member of the National Nonpartisan Committee that produced the groundbreaking report, Dying in America, Improving Quality and Honoring Individual Preferences Near End of Life. Currently, he is a member and former chair of the National Academy of Sciences Roundtable on Quality of Care for People with Serious Illness. He has endowed chairs at Brookings, USC, UC Berkeley, the National Academy of Medicine, Harvard Medical School, and funded 16 undergraduate scholarships at Princeton. He received an honorary doctorate of humane letters from USC. Please join me in welcoming our panelists. I think we're going to move to Dr. Bomba now, and she's going to do a presentation for us.
Good evening, everyone, and thank you for the kind introductions. I'm just going to minimize this. The talk this evening was on personalized care for the patient and family, and the only way that this is done is as well as it can be by having patients and families, or all of us as individuals, begin to share what matters most and who do we trust to make decisions. That's the process of advanced care planning. And I thought I would start with a very brief personal story. This is my mom, affectionately known as Babshi, in May of 2007, with my daughter, who's a palliative care physician at her medical school graduation. My mom passed away in December of that year. But the story began in 1992, shortly after the Patient Self-Determination Act and the ability and the federal right for us to be able to appoint who we trust to make decisions, and also to put into effect specific documents. Forms are just not enough. You need to have a discussion. But my mom decided she really wanted to have an advance directive, and wanted me to be her spokesperson, her healthcare agent. And she asked if I would do so, but also do what she wanted, not necessarily what I thought was important. We went through the conversation, and she did her forms, but she said, this is not enough. We need to have a family meeting. We need to have a family discussion. And so we had our first healthcare proxy party at Thanksgiving at our home, and we hosted it annually since 1992 until her death in 2007. What was important was that she shared what mattered most to her, which at that point in her life were her grandchildren, and she wanted to be as well as she could be to be that grandmother, Polish Babci. And she also said, I've chosen Pat to be the person who will make decisions if I'm not able to, but if I'm not able to, I've chosen two of you of the other four sisters as the backup. What she did wisely was said to the two sisters that she didn't choose, I didn't choose you because I loved you. The point of talking about the story is the importance of not just doing forms, but also doing family discussions to be able to ensure the kind of personalized care that people desire based on what matters most to them. Fast forward to 2005, 2006, as she was beginning to have a bit more difficulty with thinking, but still had the capacity to make decisions. And when she came to live with us, she had the opportunity to meet with a physician, a new physician, because it was a new state. And the physician talked to her about the MOLS form at that point, and talked about medical orders. At that point, she was 80 and had desires about things that she wanted to receive, what she didn't want to receive. And she was well educated about what the process was and was able to complete that form, a set of medical orders, and they were reviewed and updated every 3 months. She traveled to my niece's wedding in September of 2007, but the family needed to understand these medical orders, what they meant, as she traveled from one daughter's to another. And as it turned out, she ended up becoming acutely ill when she was in Pennsylvania, and those orders needed to be impacted and used. It's not enough to just have forms. It's important to have those conversations, but having the medical orders, the physicians who saw her acutely were able to manage her care based on what mattered most to her at a time when she could not speak for herself. She ended up having initially a kidney infection that was then found to be related to some underlying abdominal cancer, which was then treated. But when she was at the hospital, she asked that she would still want to go to her granddaughter's wedding, which was another hour or so away. The physicians were able to manage her treatment, and she was able to get to the wedding and be able to do 2 weeks of IV treatment with antibiotics, and then 2 weeks of subacute care. When she returned to Rochester, she was no longer the same person that she was before her trip. She chose not to undergo treatment for her cancer. She wanted to enjoyed the remaining part of her life. She was on hospice for several months and required significant symptom management for blockages in her intestines and her stomach, and the intensive symptom management that palliative care provides. And her family all needed support. She was able to die as she wished, peacefully in our home after, again, several months on hospice. But it was really, truly the conversations over our lifetime that prevented some of the conflict that otherwise might arise. So when we think about palliative care, I think in terms of it being the best care model, it really is a team-based approach, holistic care with expertise in medical, psychosocial, spiritual, legal, cultural, respecting cultural aspects. And I think in terms of three key pillars to help people understand the difference between palliative care and hospice. Palliative care was based on the hospice model, but advanced care planning and my mom's story illustrates one of the key pillars. Pain and symptom management is important, as well as caregiver education and support. Combining these three pillars of palliative care with chronic disease management provides best care for patients and their families, particularly those with serious illness. Palliative care should start from the time of diagnosis, and it may be 20 years, it may be 1 year, it may be less than a year, as it was in my mom's case. This hatched line basically is a time when it wouldn't surprise physicians and other providers that the patient might die. As you move along this timeline, you'll see just mathematically that patients in that last year of life benefit more from palliative care and really focusing on what matters most, having these conversations more intensively over that period of time. And goals can shift. Oftentimes people want to focus on having more time and then moving to having function and being able to manage their care and, for instance, not end up in a nursing home, and then ultimately moving to comfort care. The linear line is when people are appropriate for hospice. This triangle relates to bereavement. But the important piece is who can provide this care, and we'll have some discussion about that as part of the panel discussion this evening. What we did in our own community back in 1997 with the prior IOM report, Approaching Death, Improving Care at End of Life, in our community, as Catherine said, data is important. We conducted a community survey of hospital systems, our nursing homes, our home care hospice agencies in the 6-county region, and looked at the data to say, are we doing any better than the rest of the country in terms of end-of-life care in the late 90s? We weren't in terms of advanced care planning, pain management, or hospice referrals, and we brought together a community initiative with a broad base of 150 individuals, including consumers, to really focus on how could we improve palliative care and end-of-life care. And we focused on three major areas, recognizing there were regional variations in the cost of care at end of life. And that's not something that people were necessarily wanting to talk about it at that time. A significant functional health illiteracy and the importance of healthcare professionals having good communication skills. When we launched this initiative in 2001, and I was privileged to lead this when I came to work at the health plan, we had a commitment to leadership, working with our health systems, sustainably integrating this into our core functions in the health plan, care management, our marketing, any of the functions that we would be using to ensure that our members, providers, and our hospital systems understood what palliative care was. And data collection was an important part of this initiative. 20 years later, we recognize that as we developed payment models, that they've changed over time, and that the future really is continuing to work on with our value-based partners in terms of that payment model, digital transformation and enhancement of some of the systems we've developed, and sustainability. We started with 4 major programs focused on advanced care planning for everyone 18 and older, and a program called Community Conversations on Compassionate Care, developing the MOLST, which, as Katrina said, we're a founding member of National PULST. We subsequently added guidelines for tube feedings and peg tubes, focused on principles of pain management, but over years added opioid use disorder, recognizing these are both public health issues that need to be balanced. We've developed a pediatric palliative care program and multiple initiatives focused on community education and professional training, recognizing the importance and value of having both of these to ensure well-informed shared decision-making. We created a community website called compassionatesupport.org. And 3 years ago, we redeveloped and redesigned the website to include 2 population health websites, one for everyone in the population, including pediatrics and palliative care, advanced care planning, and one for those with advanced illness and frailty, which is the MOLST.org. When we first started 20 years ago, we did EPIC conferences, 2.5-day conferences twice a year. Over the course of time, we did multiple conferences focused on MOLST, webinars, and in the past several years have been trained in Project ECHO and have developed ECHO MOLST as a means of teaching palliative care. All of these initiatives require support and require connections between health plan and our providers, our members, and the healthcare systems. I'm going to just talk a little bit about advanced care planning from a population health perspective. And I focused my story on this because, as Catherine said initially, the value of advanced care planning was really seen in the midst of COVID. Our 2 complementary programs focus on everyone 18 and older, not only having a healthcare proxy, which is the key document in our state, but also having this family discussion that I described. For those with advanced illness and frailty, having medical orders. And whether you have a MOLST or PULSE program, or no matter where a state is in the development, people with advanced illness and frailty will have medical orders in the different health systems. What the program does is ensure that the medical orders are a care transition tool, and the orders travel from one site to the other. What we learned during COVID is that the 3 key orders were related to resuscitation preferences, preferences for respiratory support, and hospitalization or transfer in between facilities. The other life-sustaining treatments obviously are important, but those 3 key medical orders we saw updated and reviewed and changed about 20% of the time in our EMOL system in terms of reviewing that data. It's important as one begins to look at advanced directives and medical orders for people to understand the differences, and they're outlined in slides, and these slides will be available to you. And it's important to understand that medical orders are not advanced directives. It's about what people want in terms of current care. When my mother had her MOLST orders, again, those medical orders were able to be followed by physicians as she traveled from one state to another. Medical orders are on. There are cohorts of individuals with advanced illness and frailty that are appropriate to have these medical orders placed by the providers to ensure that these are done correctly. It's important that the shared decision-making is done for the individuals who are appropriate. What we found during COVID is that there were an additional group of individuals who were not necessarily appropriate before COVID, but acutely became obviously appropriate for having medical orders at that time. This is a program that really focuses, our advanced care planning program focuses on storytelling and 5 easy steps. And the MOLST program, as I said, is an important program, a care transition program that applies shared decision-making so that when people are in the emergency room, where the majority of people with advanced illness often are not able to make their decisions because they're so significantly ill. That is the value of the program. And in our state, it's the only forum that our EMS can follow. Not only do not resuscitate, but do not intubate and do not hospitalize. To be able to implement palliative care in any of the elements, it requires multiple dimensions. And all of the asterisks recognize all of the recommendations from the 2014 IOM report. And these are what we've used to help our providers and health systems in partnership with the health plan to move it forward, helping develop culture change and providing them with the professional training, leveraging existing payment streams. And we were the first health plan in the country to develop a funding model and a payment stream as far back as 2008, and then moved over to the new CPT codes when they became effective in 2016. Culture change is important because it's moving away from a simple DNR order to a more thoughtful discussion, including a care plan that's required for a 24/7 if people choose not to be hospitalized. It involves partnering with spiritual leaders, our community partners in advanced care planning. And we've worked closely with our Black ministers through the sorority of Black African-American nurses in our community to send the message on advanced care planning. We have multiple venues, as I said, for professional training, and we conduct community education, not only for our members, but also through the community. And we provide the tools that our practices, our nursing homes, and our hospitals, as well as sharing them throughout the state, require in terms of system implementation. We've also been able to lead legislative advocacy that has allowed this program to move forward. And we've developed a registry which has been in existence for the past decade, and it has provided data that we are able to share with HIPAA compliance, obviously, to the facilities that are using it for their facilities. During COVID, we found that people were calling in asking to have more discussions and to review and update their medical orders. More information on any of these programs can be found on compassionatesupport.org as well as molst.org. And with that, I will close and stop sharing and turn the program back over to Katrina.
Thank you, Dr. Bomba. That was great. A lot of really good information, certainly for myself, and I think probably the entire group, the importance of the advanced care planning and having a MOLST process in place at our facilities is just extremely important. So greatly appreciate that. I think the next thing we're going to do is just quickly have some opening remarks from some of our panelists. Dr. Barrera, do you have a few things you want to say before we get started with the questions?
Thank you very much. I think the one message I'd like to give to our executives is that one of the barriers for palliative care to happen are our executives. And the reason for that is we did two major surveys in the nation, one to the CEOs of all the NCI cancer centers and a random sample of the non-NCI cancer center executives, and with very good response rate. 10 years ago, they said, well, we're not sure palliative care is very useful, and certainly we're not planning to invest. This year, last year in 2020, they were saying 90% of them, this is very useful. However, only about 50% of the NCI CEOs and 23% of the CEOs in the non-NCI cancer centers, that are where most Americans get treated, were planning to invest in this area. And so it's the same, makes the same sense as saying, I believe in radiation therapy, but I'm not planning to hire any radiation therapist. So it might do itself, or somebody else might do it, or we might find somebody who has time in our organization to do it, but we're not really going to do it seriously. Now, when we asked them, what are the barriers? That was the more interesting part. The barriers were two. One of them is financial constraints in the institution. The other one was poor reimbursement. And the data is overwhelming. And that's what I think might be the message that I would like you to take with you. It's administrative malpractice to say that. There is a huge amount of data that shows that there is an enormous financial advantage by establishing specialist-driven palliative care programs. And that advantage, on the other hand, is measured at the back end, at the non-compensated ICU days, at the non-compensated MRIs or pembrolizumabs for 5 months, or multiple visits to the ER. So good planning means don't only look at the front end, look at the back end of the operation, and then you'll find that each of these people you hire will give you 5-10 times the amount that they cost you on a yearly basis. So if you have to take something with you, that would be the message I would want you to take back and to reflect on. And hey, do a Google search if you don't want to do a PubMed search, and you'll find that there is an enormous amount of evidence that will help you go to your boss and say, you know what, I think you're wrong. I think this makes a lot of sense, not only ethically and clinically, this makes an awful lot of sense financially.
Great points. Great points. I think you're right. You've got to look at the big picture. And as we go into value-based care and more at-risk populations, we're going to see that more and more. You're absolutely right. Mr. Schaefer, before we get to the questions, do you have some opening remarks you want to make?
Yes, I wanted to say how flattered I was to be asked to participate in this panel, as I'm not a clinician. I suspect the invitation came due to my experiences related to running large healthcare organizations and my participation in the National Academy Committee that produced the Dying in America report. However, my interest in palliative care is personal as well as professional. There are many important clinical issues that Dr. Bomba and Dr. Guerra are going to discuss, but as a non-clinician, I can tell you that among lay people, there is great ignorance about palliative care options. During the research phase of Dying in America, we heard from many people that had had difficult experiences during the final days of a loved one's life. In the last century, death had moved from a family-oriented event to a medical event. And this observation struck a chord with me. I've been thinking about how care is delivered at the end of life for as many years as my father has been gone. My father was a man who had been in charge throughout his life. At the end, however, his experience mirrored that of so many who die in circumstances that do not reflect their preferences or their values. Participating on the NAM committee that produced Dying in America was an opportunity to help design a framework for thinking about the broad array of issues related to managing pain, coordinating care, encouraging advanced care planning, and supporting caregivers. Among the most critical findings was the recognition that the process for making decisions about palliative care and end-of-life care should begin early in life and should continue throughout the life cycle. Pat described a personal story that describes what should be happening. But let me tell you, that is very rare. In focusing on how to start those conversations, some committee members recommended that in order to improve awareness of palliative care options and personal preferences, families should begin this conversation when their children get their driver's licenses, because those kids may be in a situation where palliative care is an option. However, by sharing those conversations with clinicians, families could help transform medical culture to support advanced care planning before a person is incapacitated and ensure that patients get the care that honors their preferences. We also learned that when palliative care is needed, the team is needed to deliver palliative care, and it includes physicians, nurses, social workers, and for many people, spiritual advisors. And getting all of that coordinated is a complicated issue. However, once we understood the nature of these interconnections, we developed a roadmap for policy change that leads to team-based approaches to improve quality of life and reduce suffering for people, not just near the end of life, but also for people with chronic or serious illnesses. Since that report was issued, there have been significant progress with respect to increasing access to palliative care. As many people in this audience know, today, 72% of hospitals with 50 or more beds have a palliative care program. These hospitals service about 87% of all hospital patients in the US. And access to palliative care in community settings is also improving, but not as quickly. However, access does not mean that patients actually receive the care they want or the care they would most benefit from. It's also disappointing they're not further along in implementing the recommendations in Dying in America, which would enhance palliative care throughout the life cycle. The challenge is that health systems reflect not just science, but cultural values, professional norms, and politics, which must all evolve if we're going to accelerate the rate of change in palliative care. And a significant part of the problem, which has already been mentioned, is that fee-for-service reimbursement, especially in Medicare, incentivizes an acute care model that does not meet the needs of seriously ill patients. Fee-for-service reimbursement rewards volume, not value. It fragments care and encourages ER visits, hospitalization, nursing home stays, and futile care that people often do not want. In addition, fee-for-service lacks the financial incentives to integrate the medical and social services I described. And bringing that together would improve quality of life for patients and also, and this is very important, help buffer caregivers from depression and other problems that occur as they deal with people with serious illness. However, I've got to say this given my background, it's not enough to change incentives for providers, payers, and patients and implement quality standards if we really want to expand palliative care. We need to learn how to measure the benefits of palliative care, incorporate these metrics into quality standards, and then pay providers more for delivering high quality palliative care. We know that palliative care can improve quality of life. And if people are near the end of life, it can allow them to die consistent with their values. So there's an urgency to improve the accessibility and quality of palliative care because of the increasing number of elderly Americans who will live with chronic and serious illness. Panels like this keep the conversation going about how we can remove the barriers to palliative care and how we can motivate clinicians to refer patients to palliative care programs. Hopefully, we can also inspire new leaders who will support redesigning the healthcare system to elicit and to act on patient preferences, whether living with serious illness or near the end of life. And that's your non-clinician point of view.
Well, thank you, Mr. Schaefer. I think that was incredible statements, and I think we're all in full agreement with you there. I think we've got great opportunities. The more we talk about it, the more ideas we're going to come up with. It's not an easy answer in any way, shape, or form. We just got a great question from the audience, and I want to read this because I'd love for each of you to answer it. It says, what can we do to encourage cultural sensitive conversations surrounding end-of-life discussions? It says in most sorry, it just jumped on me. In most cultures, it's considered taboo to talk about dying with the elderly. On the other hand, some countries, like in Europe, dying with dignity is a routine conversation. So when we think about those cultural sensitivities and the taboo to talk about this, and I think we all have run into this a lot, the challenges around talking about dying with dignity, you know, how do we change that in America? And I'll start with you, Dr. Barrera.
Thank you very much. I think when we get ill of any illness, the first thing we want is that illness to go away, because that's the reality. So for 21 years, I've been at MD Anderson. Nobody knocked the door and said, I'm coming to MD Anderson because I want to see Barrera. They want to have their cancer made history. That seems to be our motto. And so it's important to realize that when we get ill, the first thing we want is to get rid of that disease. But unfortunately, 100% of us sitting here today are going to die. And that the vast majority of us, unless you live in Texas, are going to die of a chronic illness. Here in Texas, we got other stuff. We got 18-wheelers, we got shootings, we had other things. But you are likely to die of things that are chronic illnesses. And so it's an important point to say that these things are compatible. And the motto that you might use is what we developed a number of years ago when we said goals of care, goals of care. Goals of care don't help very much, because I've asked your goals of care. Well, my goals of care, doctor, is kill my cancer, cure me. No, I can't do that. Well, my goals of care is turn it into a diabetes and have me live 30 years and see my grandchild graduate. No, I can't do that either. So it becomes like going to a restaurant and the waiter comes and he says, well, what do you want to eat? I would like to eat chicken. No, we don't have any chicken. Okay, I like beef. No, you can't have beef either. And at some point you say, well, what do you have? Because that way we can discuss it together. We came up with goals of car. And goals of car means what you do. In Texas, if you have pulse, you have a car. And then what do you do when you get a car? You buy a car with the best goals. You want to go places, you want to go to the beach, you want to drive, you're going to go to work, and that's your goal. And you can be unrealistic about what might happen to your car. You might be hit by an 18-wheeler. They might take your car away when you park it in Walmart. You cannot buy insurance, or you cannot lock your car after it's disappeared. And you cannot, put a seatbelt after the accident. So the question is, what do? You buy your car, you want the best for your car, but you take precautions in case things go bad. When you get a disease that is reasonably serious, do the same thing as you do with your car. That is, go for the best, go for the cure, go for the beach, go for whatever you can do to get your disease go away. And at the same time, think about who would move with you, who would you move with if this has to happen. Funeral arrangement, who keeps the money, how do we make arrangements? And that way you do not have to go from one to another. You can have both, and without changing your goal, you can still go for the plan B and put it in place. So I think having that mind that we can talk about the two things at the same time might help that make this dialogue a dialogue of integration of the conversation rather than being seen as the loser conversation. That's what we use for some time now. And many colleagues find that it helps their patients, but it also helps them in the way they internalize having those conversations.
Very nice, very good. Dr. Bomba?
Sure, I'll just build on that and think in terms of the different cultures that exist. In our state, in Queens, we have 140 cultures. I mean, so you have to think about what matters most in that culture, and also recognize that there's a degree of acculturation. You can't assume that a certain culture doesn't want to talk about death and dying. You have to look at that individual to be able to ask the patient. That's the simple way to be culturally sensitive. So that's what I would say is the first thing, building on what Dr. Barrera said. I think the second is community education needs to happen in a way that the community, and I gave a very quick example of what we did with our Black ministers and our African-American nurses, who really took, each one had a church, and they partnered with the minister to be able to talk about and demystify advanced care planning, and to be able to educate. We did similar in the Latina community by having bilingual sessions and really educating those in the community to be able to go out and talk about it and normalize the conversation. The other piece that we've done is think about future care planning. Everyone thinks about, will I have enough money? What am I doing with financial planning? What am I doing with legal planning? Do I have a will? Those are kind of normal activities, but why are you doing it? It's because something may happen and you may lose capacity, the ability to make decisions. Someone else may need to decide. So kind of packaging that together as part of future care planning and saying this is really the important piece. It's really about what would happen if you couldn't make those decisions, and what would be the burden to your family, and what would be the potential conflict that comes out. So we try to bring it into a much more normalization, if I would tell you. And in doing that, we've been able to change culture, at least in our service area, by using sort of a multimodal approach, so to speak. But always not focusing on what is it that you want when you're dying, as much as what matters most in terms of present. And that kind of goes to the same idea that Dr. Brewer spoke about. You know, what matters most to you today, and something could happen where you lose the ability to make decisions. Who do you trust to stand in your shoes? Just as much as it's normalizing what happens if you can't make decisions and you have a power of attorney for financial decisions. So it's trying to get people to think more broadly in terms of future care planning.
And just quickly, Mr. Schaefer?
Well, one of the things we learned as part of this Dying in America report is there are 4 or 5 different ways that these discussions can come up. As I mentioned in my remarks, the notion of having a discussion, a family discussion when a child gets a driver's license, it sounds a little macabre, but it is a legitimate conversation to have. I think what is happening, though, in the United States is increasingly people are becoming aware of this as our population ages and people have friends or relatives that have gone through this process. When I was on the committee and you know, I told people who were working on this issue, almost every person I talked to had a story themselves, and I always ended with, and that's not going to happen to me. And so I would say, well, what are you going to do? And then we talk about advanced care planning. I think there's also a tremendous role here for physicians. Primary care physicians should be initiating this conversation, but it's very important that the connection is made with specialists, because you know, most of the time when someone needs palliative care or is near end of life, the primary care doctor is not the one who's providing the care. So the entire educational system for physicians, I think, has got to be redone, and doctors have to be willing to step up on this. I know they're trained to diagnose and treat, but at a certain point, as Pat says, you know, that isn't going to work. The other thing is the legal system, as Pat has mentioned, and then spiritual advisors. And in many different cultures, the source or the spurring the conversation has to come, or is more likely to be successful if it comes from one or another of these centers. In other words, in some cultural milieus, having the family discuss it is okay, and some it isn't. And in those situations, doctors ought to bring it up. Sometimes people are very, very focused on estate planning. This is part of estate planning. And clearly in many communities, it's the spiritual advisors who can communicate and get people to think about it. But we need to educate the lay population, people like me, and we really need to educate physicians.
I think you made a really good point. So one of the things we've talked a lot about in the health system is how do we have it become part of the normal conversation during your annual primary care appointment, right? How do we
Right.
make that just once you turn 18, all of a sudden that's just part of the normal conversation? I think you make a really good point. So it doesn't become a cultural taboo, but this is just a normal conversation you have with your physician, just like you would have, and are you having any pains? Or you have, any other conversation you would have during your annual wellness visit. So I think you guys make great points. So Dr. Barrera, what is it that palliative care specialists do to support patients? What would you say is that difference that the specialists in palliative care medicine do to support the patient population?
The palliative care specialist is a specialist in personhood care. We've done great progress in the management of primary diseases. We have also made great progress in the management of comorbidities or other co-specialties. Where we are awful still today is in the management of personhood suffering. And that has negative implications on the patient, on the family, but also on health outcomes. And it's complex. It would be simplistic to say that anybody can do palliative care. Anybody can do a complex discussion, an opioid rotation, manage delirium, manage pain and dyspnea. It's not, it's complex. And you need people who really know how to do it. Fortunately, not everybody is going to die the same way. Some people are going to die with a lump here, and they're just going to get tired, and they're going to go sleepy, and they're going to die. Just move that lump 1 inch higher, and that person is going to have excruciating pain, is going to die choking in blood, and is going to have dyspnea. So not everybody has the same trajectory. There is a group of people, and it's not a small group, who is going to have a difficult trajectory. And those people have a complex course. So oversimplifying the care of these patients doesn't help the patients and doesn't help the clinicians, and ultimately doesn't help the institution. That's what a specialist can do for your patients and their families. Provide the level of knowledge that is necessary to alleviate suffering, because it is complex. When it happens to us as patients, it is going to be complex. And we want to get someone who really knows how to drive that airplane. And that's the idea of the specialist.
Yeah. Just like any other specialist, a cardiologist or any other specialist, you want someone who this is what they do. This is how these are the patient populations they see. So I appreciate that. Mr. Schaefer, what do you think can be done to promote those family discussions regarding advanced care planning? We've talked about it a lot. And I don't know if there's any other insights you have there, but, in regards to the family discussion piece, we've talked a lot about the individuals. What might you do to promote the family discussion?
Well, as I mentioned, I think it has to be done in a culturally appropriate way. An issue that I'm sure we'll get into later is a big part of this. And again, Pat mentioned it in her story. You're going to need a surrogate decision maker. And so one of the issues that families have to deal with if they get to the point about being serious about palliative care and end of life is who is going to make the decision. And the big issue there is that the individual is asking someone, and hopefully someone in their family, or usually someone in their family, to make a decision based on what the individual wants, not necessarily what the surrogate decision maker would do if he or she were making a decision about himself or herself. So you have to get to a level of discussion and familiarity where you can get those points on the table. It's also appropriate, I believe, for a person, a family member, to say, I don't want to be the surrogate decision maker. I can't do this. And the other side of it, as Pat's mother did, you've got to explain why you picked one family member or one person and not another. So there are lots of things to talk about within the family circle. The issue again is this ignorance, I think, that most Americans have about both advanced care planning and what palliative care is all about. And so other players who are not in the family have to help stimulate it. Physicians, spiritual leaders, I hate to use the term lawyers, but people who help you with your estate planning to come up with this. And then again, we need to make people health literate and health care literate. And we are, as a country, a very long way from that across the board, not just on palliative care.
Good.
Katrina?
Yep.
Katrina, well, the other thing I might add is in our health plan, one of the things that we've done is develop toolkits that we've provided to our members and our providers. So we have posters that our providers can have in their office that really stimulate and normalize the culture to say this is an important element. We had a press conference as far back as 2002 with our spiritual leaders where we introduced a booklet, and we've provided it at no charge, not only to our members, our providers, so that they can distribute it and provide that education, overcome that functional health literacy, how to pick the right surrogate decision maker, what are the benefits, how to have the discussion, all the elements. And we have the same messaging on the website, on videos. We have stories. We have a YouTube channel so that people can use stories to start the conversation. We have some that are in Spanish as well, so that people can understand the value, not just from their physician, but from their peers in terms of why this is important. And storytelling, we found, is very helpful in getting the community education started, as well as that one-on-one. There's a whole toolkit that we provide, and we've integrated that into some of our normal vehicles to educate our members, our own corporate websites, but also blogs, any of the calendars that might come out, birthday reminders, any of the other kinds of things. And we work with our value-based partners to understand how is it that it would focus and work for them. But we've been doing this for almost 2 decades, and it really has made a difference in terms of changing the culture and getting people to understand the value of advanced care planning.
Wonderful. So I have another question from the audience. Jennifer is asking, what are the thoughts regarding why the topic has not been adopted and integrated as a component of holistic care by Joint Commission, CMS, other payers? I mean, you know, some payers have clearly adopted this concept, but as a whole, it's really not as integrated as we'd like to see it. What is the panel's thoughts on that? Dr. Barrera, do you have anything on that?
Well, I think part of the challenge is the players could not do this because they don't have enough palliative care doctors and they don't have enough APPs and so on. So ultimately, I think patients don't have access at this point to these services. They overwhelmingly have very limited access. So you can negotiate your way within a healthcare system, but it's not a universally accessible service. Another one is the culture. And the culture is who, a lot of the doctors of my age did not train in palliative care. I didn't either because we didn't have a specialty at that point. And they rarely understand the value of personhood care as compared to disease care. And the executives are on the same side of the board. And so basically what you consider a very important component of care is greatly influenced by your own culture, by what you learned in medical school, what you learned in residency, what you see in the hospital where you work. And that permeates into your representation into those agencies. And the executives come from the side of this is not, financially feasible. So you have the two sides, the clinical and the administrative, not understanding that on one hand is clinically extremely useful, and on the other hand is financially extremely useful. So it's a paradox, I think, in which more care in this case is great for care and for the bottom line, but you're not making it happen because the people there don't understand it. The new generation is going to do much better because they have, in my hospital, they have mandatory rotation of 1 month in palliative care, and they are twice more likely to refer patients and to send them than the older generation. So wait a bit, have all of us die, and then you'll see that things will get much, much better.
Mr. Schaefer, what about you with your background on the CMS side? What are your thoughts on that question?
Well, the financial issues tend to play out here or have historically. The physicians are trained to diagnose and treat. If you treat, you're paid by the service you deliver, and you're paid, you and your health system receive a compensation. Palliative care is kind of mysterious. There isn't a whole set of things you do and get reimbursed for. And in fact, some payers don't pay at all. So the result is, the fear is that the institution or the individual physician will lose money or lose compensation. There's also another issue, which is the cultural one, that perhaps palliative care is just a way of not treating, not doing all the things you could do, and that somehow my mother, my aunt is not getting everything that is possible. So there's an element of hostility here that, again, education is necessary to deal with. And then finally, the lack of education among physicians leads some physicians to not make appropriate referrals and not consider other options. And when someone is pretty sick and the family has not thought about this in advance, they do what's recommended by the doctor, regardless of what it is.
Well, I do think we see, at least on the health system side, and Dr. Barrera, Dr. Bomba jump in, we see a lot of very late referrals into palliative care, much later than we would like to see. I think that's something, Mr. Schaefer, just kind of what you were just saying, we see it, basically in crisis mode as opposed to in planned process. How do we start to, and a lot of this we've just discussed, right? But, knowing that it's going to take some time to get to the PCP side, knowing it's going to take a little time to get, the 18-year-old to a point that they're further down the line. What are some of the things that we could do now to help make that shift? What are some of those, from a health system perspective, things that we could start to do today to help make that shift?
Well, an early referral to palliative care is an outpatient referral. I don't believe you need to have a referral before the disease becomes reasonably advanced, because I don't think the patient has that level of distress and symptoms and decisions to make and functional impairment. But once your disease becomes serious, then you have to be referred as an outpatient. The reality is the majority of centers do not even have an outpatient palliative care center. And so there's nowhere to send them unless they get into the hospital and they are referred to a palliative care specialist in the inpatient setting. So that's one of the challenges. Structures need to be there. The other thing is, we did a study because we had the structure, but we also had the challenge of getting the patients too late. And then we did a blinded survey, anonymous survey of a large number of oncologists and APPs. And what we learned is that they thought that the name palliative was decreasing hope in the patient and family. And therefore, they did not want to send the patient too early because they were going to destroy the hope, or they're going to think that they were dying. And so what we did is we added the name supportive care. And by putting the name supportive care, within 6 months, we had a 42% increase in referrals. And the referrals went from 1.5 months to 7.2 months before death. And therefore, it was the change in the name. We didn't do anything else. Our department is still called palliative care. We're all palliative care specialists. The name supportive care in the outpatient center and in the mobile team was enough to enormously increase the number of referrals and move them much earlier, because that perception that we were destroying hope was gone. And it also relieved the oncologists, and I suspect also cardiologists, neurologists, respirologists, from having to have a 45-minute conversation about why they were sending them to palliative care, but saying, we're sending them to supportive care because they're going to help you feel much better, they're great, and then we practice palliative care when the patient arrives, but the name of the center in itself makes some difference. So get the structures and then maybe consider calling the early services supportive care. That will increase business in your institution.
I think that's superb points.
Yeah, I think there's something else we ought to talk about just briefly, and that is, changes in legislation. Here, I'm from California, and there was a bill passed in 2014 that requires the Medicaid program in California, which is called Medi-Cal, to assure access to palliative care services. And it was implemented in 2018 for adults and pediatric patients in 2019. And it includes advanced care planning, the palliative care team, care coordination, pain and symptom management, all the stuff that we think is just right. However, it doesn't, the financing of these does not occur until the last year of life. So again, it's end of life care. It's not palliative care.
Right.
And I would hope eventually that we would see legislation that hopefully on the federal level that would see palliative care as treatment for people who are in pain. And if people choose that, they should have access to it. But we're a long way from that, I'm afraid.
Dr. Bomba?
I think one of the important things is to distinguish specialty palliative care versus primary palliative care. And in the diagram that I used at the beginning, it was integrating chronic disease management and these three key pillars. We've talked a lot about advanced care planning, but pain management, symptom management, and support for caregivers are all part of this. And frankly, and I'll just speak from our service area, there aren't enough specialized palliative care physicians and teams to be able to accommodate the needs, not only of individuals with cancer, but those with multi-system organ failures, with multiple comorbidities, with heart disease, lung disease, kidneys, all of which need to have access to advanced care planning, to be able to have their pain and their symptoms managed and their caregivers supported. And the caregiver problem in this country continues to escalate as our population ages. So what we've tried to do is emphasize the importance and educate our primary care providers, also teaching them when they should be referring to specialists, and also recognizing that we need to be able to help as a health plan to be able to support people, because we grew our palliative care base 20 years ago. Many of those physicians have retired or are no longer, actually some of them got sick with COVID. And so it's an ongoing process to be able to provide palliative care. But in terms of educating our providers, there's also been an opportunity to have them refer earlier. Similarly, our care managers in our health plan, so that they can identify members and connect the dots in terms of those who need specialized care, as well as, some of our primary care providers who need a little bit more education. I don't think there are enough specialists to provide the needs for all of the patients who would benefit from palliative care. But you can't expect to have primary palliative care without education and without providing some level of compensation as well. The only other thing that I would say from a system perspective, not for all of palliative care, but at least for advanced care planning, NCQA has a new advanced care planning measure. And I'm excited about that, because I think that's at least going to move the needle in terms of advanced care planning. The focus is on people who have advanced illness and frailty, but health plans will need to work with health systems to be able to make sure that, if you measure it, you need to be able to make sure things happen. So it goes back to what Catherine said at the beginning. It's all about data. And so our health plan is preparing to see where we're at with the codes that can be used. So I do think, I think it's the beginning. I talked to NCQA in 2005 about having a measure. It's a little frustrating that it takes time to have this move ahead, but I do think it's in the right direction.
Excellent. So we're getting pretty close on time here, but I want to ask a couple more questions. So when we think about barriers to referral, right? So we talked a lot about families and we talked a lot about advanced care planning. What do we think, and I'll ask Mr. Schaefer first, what are the barriers to referring to palliative care?
Well, again, layperson's perspective, but fairly heavily educated courtesy of the National Academy. The primary issue is confusion about what palliative care is. Most people don't know what it is, don't understand that it's available. Second, there is very little knowledge about what resources do exist, even if you decide that's what you want. There's also, and we mentioned this earlier, clinicians' reluctance to refer patients. And, I hate to say it, but there are many physicians, I was trained to diagnose and treat. And sending someone to palliative care or hospice is a defeat. I've failed, and I'm not going to allow that to happen. So we've got to train clinicians. There's also reluctance, as I mentioned earlier, on behalf of some patients or some families that somehow they're not getting what could be the cure. Again, from a layperson's point of view, you get sick, and the healthcare system is supposed to intervene and cure you. That's why you go to the doctor. Okay, that's why a lot of people still think they can smoke. If I get sick, they're going to cure me, and so there's reluctance by some, patients and families to be referred. And then there's the question of eligibility and compensation. Not many health plans provide a palliative care benefit, and most of the federal, the Medicare program provides disincentives. If you're in Medicare Advantage, which is a program that really does support population health for most treatments and most parts of the healthcare system, the only benefit you get that would allow you to get palliative care is hospice. And that is a benefit that is separate from the way in which Medicare Advantage is funded, and the Medicare Advantage plans lose money on that. So there's a disincentive, if you're a Medicare Advantage plan, to refer people to palliative care or to hospice. So I think there's a whole bunch of barriers, and we've got to work on all of them.
And then, Dr. Barrera, we've talked about this. You mentioned, some of the barriers related to healthcare organizations and investing in palliative care programs, right? You talked about how it's kind of a lag measure that you're going to see the results. But why do you think, you talked about the fact that there's a lot of research out there and there's a lot of data out there. Why do you think, with all of the value-based conversations in healthcare, why hasn't there been more of an buy-in, for lack of a better word? Why haven't we seen more successful integration in the large health systems related to palliative care?
Well, I'll tell you, for example, in my institution at MD Anderson, there has been, it took me 20 years of going from one door to another on my knees to show data and to show my executives their own data, to show them the financial data. And then it took a long time to change that culture. But you need to have a passion, and you need to have the time, and you need to go and knock into doors. And at some point, you need to make it more safe for them to fund it than not to fund it, because then it becomes evident that if you say that Brera doesn't pay his salary because of the billings, Brera will hit you back with the enormous amount of ICU monies, pembrolizumab, and MRIs and so on, and you're going to look bad. And so then you get the chief financial officer and MD Anderson saying, hold it, guys, don't say that. This is not true. There are data there. And now you change a little bit the pendulum, and the culture is different. So now our department is the largest in the United States. We have more than 40 or 42 between physicians and APPs working every day, and we're going to get more. And the reason for that is they saw where the money is. One of your colleagues there in the chat made a wonderful point. CEOs and executives exchange every 5 years. They look at the short picture, not the medium to large picture. Anderson is a Southern institution. Anderson is a patient institution. They're not like those Northeast methamphetamine-ridden organizations that hire you, give you a lot of money, and in 2 years they want the results or you're out. That's not the case. I've been a department chair for 21 years. I would not be able to do that in the Northeast or in the Midwest because somebody would kill me before that. So impatient institutions that think longer term, then it does integrate. They see the advantage of making the investment now and collecting down the line by saving in those cases. And that actually declogged our ICUs and our inpatient areas during the COVID crisis. Anderson never had a problem, but palliative care had a huge role in helping prevent those ICU admissions, helping those patients get out, treat the patients in the community virtually, etc. So the perception needs to change, but you need to get yourself inside that nuclear changer. It's hard to get it from the literature. You need to get people inside who will force that change to happen. And then institutions are adopting it. What your challenge is, go back and think about what is your institution doing and what is your institution not doing. And you'll see that there's a great advantage for you as a health executive. This is something where you can really make a difference.
Perfect. Dr. Bomba, Dr. Barrera just talked a little bit about COVID-19, and Lord knows that's all been top of mind for all of us for the past year and a half now. So what have the impacts of COVID-19 been on palliative care? You brushed on it a little bit during your presentation, but what do you think, number one, where has COVID-19 really made impact from palliative care, but then where do you think it's going with MOLST and POLST, and how do you think that will enhance the utilization?
I would tell you that the data can drive the answer, and the data that we have comes from our registry. And so during the peak, and obviously New York City was at the hub of COVID-19, and during that period of time, we saw exponential growth in the number of individuals that were in our registry, the number of individuals providers who were enrolled to participate in the registry. For major large health systems in the metropolitan area using eMOLST for about 5 years, patients were calling in to be able to update their medical orders. We saw 20% of those medical orders turning over. We saw also, I mentioned earlier, the most appropriate people. We saw a second subset who would not have been appropriate, who needed orders done immediately. And our registry is not just of forms, it's an online completion system to drive the right process, to make sure that capacity is looked at, prognosis and health status. And most importantly, going back to something Dr. Barrera said earlier, that the patient's goals, what matters most to them, are documented and they're available across care transitions. We also saw that people came in from all parts of the country to help in New York City. And during that period of time, people who did not understand the ethical and legal requirements under public health law in New York, which is it is the most complex in the country. We're able to follow that by having an online system. And in fact, we've spoken to other states about how they could build a registry similar to that. So the value of advanced care planning, most importantly, came through very clear. And the importance of doing these early conversations that we've talked about earlier is clear. And I do think now that we're going to measure, particularly for these very sick people that we've been talking about this evening, I think it will drive it even further. But it wasn't only the advanced care planning, it was also obviously the pain and symptom management that was pretty clear in COVID. Our palliative care dogs worked really, really hard, not only in the New York City area, but throughout our state. And I think it was enough for people to see the value. Everything that Dr. Barrera said is true. I think for any executive that's on the call this evening, I would hope you wouldn't have to have a personal story to motivate you to move forward in the way that Dr. Barrera's had to knock on doors for 20 years. What I've seen is when people experience that personal story, they began to embrace palliative care, whether on the health system side or on the health plan side, not just in our own neck of the woods, but throughout the country. That's where I think change starts. It's unfortunate that you have to have your own family experience to understand the value of palliative care. But I think that has made a huge difference in the systems where we've seen it. I certainly know I've gone through 4 CEOs during my time. The 4th has just started last month, but all of our CEOs understood the value of palliative care. Unfortunately, some from their own family experience. So I think that's my message to the folks on the line. Don't wait until you have to have your own personal experience. I know I've had one more recently with my son, and I have been a strong advocate, and I've seen the value, not only in terms of advanced care planning, but pain management and support. And I would say that our systems are complex today, and they're fragmented. And so palliative care is necessary when the work isn't being done upstream. It's not being done in the doc's offices in primary care. It's not being done in the nursing homes. And so we need to move palliative care, not from the hospital only, but to the outpatient area, as Dr. Barrera said. That's another piece that I would strongly recommend to the executives this evening. It just can't wait until people are in the hospital.
Yeah, and I think I thank you. I think we have an opportunity to, for lack of a better word, capitalize on COVID, and capitalize, from a health system perspective, capitalize on the movement that we've seen towards home-based care. We've seen a real movement across the country towards home-based care, which was coming anyways, but it's really escalated quickly due to COVID. And so as we think about clinic-based care, now is the opportunity to have these conversations where people are much more open to them. Just through everything that's happened through COVID, it's not as taboo as it was. It just isn't, to have these kinds of conversations, because so many people saw their loved ones or family or friends or whoever who didn't have advanced care plans in place and had to make really difficult decisions over the phone, or just really, really tough scenarios. And so I hate to, say utilizing COVID as an opportunity, but utilizing it to help educate people as to why these advanced care plans are so important, and taking that towards, how can we make things better in the future, and using that as an example. And I think that's an opportunity for us across the board.
I think you're spot on, Katrina. And I think that we certainly saw that in our state. We've seen it across the country. And I don't think we're going to go back. And while COVID represents one aspect, what's going to happen with the next public health emergency?
Correct. Mm-hmm. So I don't know about everybody else, but we all need to go make sure we have our advanced care plans and all our families do. That is for sure. I guess we're right about at time. Do we have any more questions? Well, I just want to take a minute to thank every one of the panelists. Y'all have been incredible. And a huge thank you to everybody here on the phone today.
Great discussion, guys. Thank you so much.
Thank you all so much. Have a wonderful evening.
And thank you for moderating. You did an awesome job, Katrina.
My pleasure, anytime. Thanks for asking me to moderate.
Yeah, you are great, Katrina.
Oh,
Thank
you're
you.
so sweet.